This conference will now be recorded.
So, as you all heard, we're now recording. This is the first of 2021's high-risk advanced, recurrent advanced prostate cancer group. We've got a big old turnout for our first meeting. We do record the meetings. Anybody who prefers to remain anonymous is very welcome. Just let me know ahead of time, or you don't have to identify. If you want to participate and identify under a pseudonym, that's just fine too. We record the meetings, A, so that you can go back and listen again if you miss something, and B, because we have a lot of people, usually anywhere from 30 to 50 people that listen to these meetings each week on YouTube. So I think we've got some new names. And let me just identify who I think they are. John McPhee, have you ever been with us before?
No, I haven't.
Okay, well, welcome. And I'm just going to make a note of the new names. We'll tell you what happens to you new guys. It's nothing bad, don't worry. But we'll tell you what happens to you new guys, and if you wish to participate or not. Now, Vern, I think you were with us before, is that right?
That's correct, yes.
Yes, I thought so. And Walter, is that New York City, Walter?
Yes.
Hello, have you been on this group before or not, Walter?
No, I guess I thought this was the intermediate group, but this is, you said this was high risk.
Yes, it is. You're welcome to stay and listen.
Right.
If you like, but I won't ask you, I won't treat you as a new guy because you don't fit in the group, but you're very welcome to stay and listen. So just for your benefit, it's second and fourth Mondays are the low and intermediate. First and third Mondays are the high risk, recurrent and advanced.
Thank you.
Okay. And let me just look and see. I think there was one other person that I thought might be new. Oh, Robert McAleese, that's it. Robert, you're muted right now. Have you ever been with us before? I know you wrote to me. Have you?
Yes, I've been on before.
Right, you're from Sacramento, right?
Yeah, Sacramento and San Francisco.
Right. I've got a question for you, but we'll wait for that. So I think that means that we're fine. I got a message from Al Latimer. Maxed out. I don't really know what that means because we have capacity for up to 150 video icons. So it could be something at your end, Al. I don't think it's something from our end. But I'm sorry. And yes, you're still with us. So you should be able to do that. I'll let one of the other moderators handle that with you under our new protocol. So a couple of quick things. First of all, we do have a new protocol, and the features of it are that one, we're going to rotate the chair, so you don't have to listen to me going on and on every week. I think the program is going to be the first Monday will be me, the second Tuesday will be Peter, the third Monday will be Herb, and the fourth Tuesday will be Len. So that's how we're going to do it. Secondly, we are only going to take a maximum of 3 new guys each week. And if we have more than 3 new fellas or caregivers, we'll invite them back and give them priority the following week. And we'll try and take them as best as we can in order of their arrival on the group. And we're going to try and streamline the time we spend with new guys. So we're going to conduct it more as more of an interview rather than letting it be free flow. And I think, yes, and the most important thing is, if you arrive after 10 minutes after the hour, then you will not get polled whether you want time until we've gotten through everybody else. So anybody coming in 15 minutes or 20 minutes late will have to sit tight, and if we've got time for them, we'll go back to them later. The idea being that we get started right by 10 after, which we're pretty close to right now. So that said, and John McPhee identified as the only new person, that is to say the only person who's never introduced themselves. Am I correct in that, or
You're
is there
correct.
anybody else who's only been on here for the first time that I've missed? Okay, let me go down and see who needs time today. We will now be sure to do this at the beginning of each meeting. Let's start with Al Latimer. Al, would you like some time today?
Yes, I would.
Okay. Jake, would you like time today?
No, thank you.
Okay. Dennis C, would you like time today?
No, thank you, Rick.
Okay. Peter K, would you like time today?
Yes, please.
Okay. Jerry P, would you like some time today?
No, thank you.
Okay. John A, would you like time today?
No, thank you, except to say that I did my homework, and thank you, Peter, for writing that all up.
Actually, I wrote it, but that's okay. To see what Peter writes, you have to be on the low intermediate reminder list, or you have to be signed up to our blog. Okay.
Okay.
Because the jewels get reprinted, get reposted onto our blog. Not everyone, but the jewels do. Okay. Robert McAleese, would you like some time today?
No, thank you.
Okay. Herb, would you like any time today?
No, I'm good, thanks.
Len, would you like time?
Got a 30-second PSA update. That's it, Rick.
Okay, that's good enough. You got time. David M, would you like time today?
Same thing, just an update on PSA.
Okay, we'll take it. Hi, would you like time today?
No, thanks. I'm just loitering.
Okay, welcome to loitering. Ben, would you like any time?
No, thank you.
Okay. Joel, how about you?
No, thanks.
Vern, would you like some time today?
One short question.
Okay. Frank, would you like any time today?
Yes, I'll need some.
Okay. Tracy, would you like time?
Nope, I'm all set. Thank you.
Okay. Ken A, would you like any time?
I have one of those 30-second PSA updates, yeah.
Okay. We're going to see who takes more than 30 seconds. All right. Peter M, would you like time?
No, Rick, no, thank you.
Dennis M, would you like some time?
Oh, I'd like to show off my AnCan sweatshirt.
Oh, yes. Okay.
For those in cold climates, it's awesome. It's warm, soft, It's already been watched. It's wonderful.
And we didn't pay him. We didn't pay him to say that. This is not a paid promotion, correct?
Correct.
Yeah, but it's got to be good for down in us warmer climates where we get cold in the winter, right?
Yeah. Yeah, you don't have one. Anyway, Dennis, would you like any time?
No update. Thanks, Rick.
Okay. Rusty, any time for you?
Yeah, I need probably 5 minutes.
5 minutes. Okay, Rusty, you got it. Rusty. Terry K, any time for you today, sir? You're muted. Unmute. Now you're on.
Yes, please.
Okay. Carl, any time for you today?
Yes, sir.
Okay. Jim G, would you like any time? Jimmy.
Oh, yeah. I want 40 seconds, please.
40 seconds.
Right.
Okay. Rusty's going to be the timekeeper because his 30 seconds is usually about 3.5 minutes. So we're going to make Rusty the timekeeper. Sylvester, anything for you?
No, thank you.
Okay. Les, anything for you?
Today, thanks, Rick.
Okay. Dr. Mark, anything for you?
I'd like 8.5 minutes. No, I could give an interesting update, but if it gets kicked down the road, that's fine.
Okay, that was Mark Finn. Yeah, no, we definitely want you. How about Dr. Mark? Anything for you?
Now, this is much better than TV. I'm going to sit in and learn from all you people of experience to share.
Okay. Jim B, anything for you?
I'll kick the can down the road as well. I like that analogy.
Okay. And Russell, anything for you today?
Nothing, but thank you.
Okay. Now, did I miss anybody?
I'm good tonight, Rick. Thanks.
Who was that? Oh, but hey, Mr. Fish, there's new rules. There's new rules, Mr. Fish.
What did I miss?
Oh, you better check. Yeah, you didn't read my reminder, but you can check. Oh no, you can't check in the window. Jake will post it in the window again just for you. The new rules are, if you get here 10 minutes after the start of the meeting, we don't poll you until everybody has had their turn. So if you want to be sure to have time, you've got to be here within the first 10 minutes.
Okay.
Okay? So them's the new rules. Okay, so we're going to start with John McPhee. And John, no, we've actually just changed this protocol. So you are our guinea pig to see how it works. And what we're going to do is we're going to ask you a bunch of questions, and hopefully you'll answer them best as you can. And when we're done with these questions, then we can dig into any of the items, and we're going to ask you if you have any questions for us. So is that okay by you?
Yep, it is.
Okay. So here we go. And my
Hey, Rick.
moderators,
Rick, this is Mark Finn.
are on.
Do you really expect to follow these rules?
We'll see. we will. Hey, listen. It is the majority. We're not going to say who voted for and who voted against this, but the majority of our 4 moderators wanted to invoke this process. Okay.
And we're going to have enforcers.
Jake's always the enforcer on these calls. You know that. All right, John. All right, John. How old are you?
75,
Okay. And where do you live?
Toronto, Ontario.
Okay, welcome from Toronto. And when were you first diagnosed?
Oh, March last year,
March
March
of
or 20.
March of
March
20. Okay. And do you recall what your Gleason score was and also your PSA level at diagnosis?
Gleason was 8 and PSA was 12.
Okay. Now, was that a 4+4, your Gleason?
Yes. Yes.
Okay. Okay. Tell us about where you're being treated and who your doctor is.
My doctor is Dr. Chung at Princess Margaret Hospital in Toronto.
Okay.
I got 5 sessions of MRI, SBRT.
Okay.
And I had 1 shot of HCR brachy.
Okay. HDR, you said, right?
Yep.
Okay, so for those who don't know, those are the rods that are inserted. Those are not the permanent. Those are not the permanent seeds. And Dr. Chung, is that Chung?
Yes.
And what type of doctor is he? Is he a radiation oncologist?
Yes.
Okay.
And I managed to get in on a clinical trial at Princess Margaret. I only had cancer on 1/2 of the prostate. And so I got radiation SBRT on the whole prostate, but the brachy was only done on the one side.
Okay. Did they give you any SBRT to your pelvic girdle? Did they treat the pelvic girdle? Did they treat the lymph nodes in your pelvic girdle?
No, they didn't, as far as I know.
Okay. Did they scan you before you started treatment? And if so, what scans did they use and did they find anything?
They did a bunch of MRIs, one of which has got the probe up your butt. That was nice.
Right.
And there was signs of cancer in my seminal vesicle on the one side.
Okay. Okay, that's helpful. Thank you. But there was no lymph node involvement.
Not as far as I know.
Good. We like that. Did you have any type of genetic testing ordered?
No.
No. Okay. Now, and do we have your contact details? Have you signed up on the website, on our website, to get a reminder? If you would like to get a reminder before each meeting, please, can you either send us your email? You can send it to info@ancan.org, or you can put it in the chat window, and we will add you to our reminder list and also let you know about any webinars we're planning, which we are. But we will need your email to do that.
Okay.
So, all right, this is a question for my fellow moderators. Did I get everything in that I was supposed to get?
Pretty much.
Well,
I would.
You want to capture the response to his treatment.
Right.
Yes.
Current PSA.
Yes. So thank you. So post treatment, what has happened?
Okay, I was put on Lupron, 4-month shot on October the 1st. So this is 3 months into that. During the radiation, I had to have a catheter put in because the swelling had pretty well blocked urinary function. That was okay. I mean, I wouldn't want to live like that if I could possibly avoid it, but it was better than sitting on the toilet all night dripping.
Right.
And it's now 5 weeks since my radiation, and everything's pretty good except for the hot flashes, which are, yeah, day and night hot flashes.
Okay, we can talk to you about that. And what about your PSA? Has it gone down to less
Oh,
than
yeah.
0.1?
Yes, both PSA and testosterone have essentially disappeared.
Okay. Okay. So, how did you hear about us, by the way?
On the web somehow, looking at various things.
Okay. It's close enough for government work. All right. So, again, let me just make sure with my fellow moderators, is there anything else we should have covered in this session? Excuse us for doing this, but because it's new, we're getting used to it. Anything else, gents? Okay.
I'm not sure I got the date of the radiation and the date of the 4-month Lupron.
Okay, the date of the 4-month Lupron was October of 20. And the date of the radiation, well, thank you, we didn't get it. It was, you were diagnosed in March. When did you start your SBRT and brachytherapy?
The SBRT started on November 9th.
Okay.
And I had every other day for 5 days, or for, 2 weeks, 5 shots. And then the HDR was on the 23rd.
Okay. Okay, so let me ask you if you've got any questions for us, and then we'll throw it out to the group.
No, not really. I was just going to listen and see what happens and what you do and what's talked about. And
okay. Well, let me start with a couple of guys that I know, at least one who has experience with a catheter, although it wasn't from radiation, and that's Peter Kafka, Peter K. And Peter, any thoughts, anything you'd like to say? And let me, and anybody else, but let's start with Peter. You're muted, Peter. Turn on your mic. There you go.
Picked up my ears because I was in the same boat as the seminal vesicle invasion, meaning the cancer spread beyond the capsule, and I mean I had surgery to remove mine. I don't know how well radiation SBRT does with the seminal vesicles, and I don't know whether brachy actually can do that. But to me, it's a red light, meaning you're going to probably have to watch pretty carefully because there's a good chance that you've got systemic spread, and you're going to have to watch your PSA very carefully and just kind of get used to looking over your shoulder because the cat's out of the bag. That's my experience.
Thank you, Peter. Anybody else here who had seminal vesicle invasion originally in their experience?
Yeah, I did. And it was ablated by radiation therapy.
Thank you, Len. Anyone else?
Rick, I also had seminal vesicle involvement, but that was during my prostatectomy. It was removed with clean margins.
Okay.
And I did as well. I had the TULSA-PRO first and then did the PET scan and found involvement and went ahead with Uray SBRT, which was 5 treatments and not much of anything, no symptoms so far. And PSA dropped to 0.013. Testosterone is undetectable on the ADT and Zytiga.
Okay. Who would like to suggest some solutions to John for his hot flashes?
I would, Rick.
Please go ahead.
Okay. I take Effexor, and I had probably 12 hot flashes a day at the least, and probably 5 or 6 at night, and it was just awful. And I used the symptom management program at UCSF, and they put me on Effexor, and I started at 75 milligrams 3 times a day, and then they put me on a longer acting one. I think it's 225 milligrams. It goes 24 hours a day, and it works phenomenally. I mean, when I'm getting towards the next dose, I might have 1 or 2 hot flashes, but that's it. And then the rest of the time, I don't at all.
Okay, thank you very much.
Could you spell that?
How do you spell it?
It's the
E.
Hold on a minute, because
Sure.
I want to give him the generic name because it may be called something different in Canada.
Canada.
Right. So the generic name is Venlafaxine. Somebody will put that in the chat window for you. Oh, I'm sorry. I should have told everybody at the beginning to watch the chat window very carefully. It is the bubble at the top, and there'll be a little number by it if there are any messages in there. We use it frequently. We include it when we publish the recording, but you need to keep an eye on it. And we'll put it in there. Venlafaxine, thank you, John, put it in. Venlafaxine. It is a known treatment. It did not work for me, probably because I had been on Venlafaxine for other reasons prior. So my body was just used to it, so it didn't help me. But it helps some men like Robert. And so it's definitely something to look at. The other drugs that are sometimes considered are Megace, MEGACE, which is Megatrol, and also Depo Provera, Provera, Depo Provera. But there are also some solutions that are not drug oriented. And one of them that we have found works quite well for men on these calls, in these groups, at least they've tried it, and then they've said they've gotten a response, is actually acupuncture. Acupuncture, there are known points for hot flashes. The acupuncturists do know the points. And if you can deal with the needles, then it is a way to go, and it gives you relief, but you have to go back every 3 weeks or so. Has anybody on the call used acupuncture? No, no one in this group, but it's been used, and it's been used with some success. Anybody else have any thoughts for John on hot flashes?
I do.
I'll just say that I agree. I've been taking Venlafaxine for about a year and a half, and it does work.
Okay,
For me.
okay. And Jimmy, go ahead, please.
Yeah, I like to wait until all of the, the pharmaceutical and substance related solutions are out of the way, because I know they're all valuable in different ways. But I always would say that for me, the hot flashes, along with all the other side effects, is greatly helped by eating less, eating healthfully, and exercising as much as you can. I think they help everything, including hot flashes. They certainly have. I have almost no side effects, and I don't suggest people exercise as much as I do, because you don't want to know. But I do know that if we eat less and keep the weight down, we're not carrying a lot of fat. It's better in so many ways. And the exercise, there's just no end to the benefit.
Yeah, and we endorse that wholeheartedly. In fact, we may make Jimmy our new spokesperson on those subjects. Anyone else? Len, did you want to add something?
No, I have nothing to add, Rick.
Okay. Any questions that you?
Rick, let me interrupt here quickly, please. If you're not using the microphone and you're not speaking, please mute yourself. It's very distracting to everyone else, and it destroys the recording. I'm talking to you in particular, Robert. Thank you.
Okay, so Robert's now muted. Thanks. So, going back to John McPhee, is there anything else that we can answer for you?
No, that's pretty good. They did, and I don't remember what it was, prescribed me a medication for the hot flashes, and I looked at the side effects, and one of them was rare, was brain cancer. And I thought, no, I don't think so.
I don't know which one it was. I do know that, on those labels, they put everything that they can think of. I might defer to Dr. Mark to say something about that. There's a big issue right now that's gotten publicity in the last couple of weeks that PARP inhibitors are causing blood cancers, but the incidence is 1% amongst ovarian cancer only. That's the only place they've done the study. And I don't think it's worth publicizing that. I mean, there was a while when people were very concerned about enzalutamide because they felt that it could cause strokes because there was a very small incidence because it crosses the brain barrier. But it just seems like everything gets shoved in there. Who would like to talk about? Mark, Dr. Mark, please say something.
So when you're doing a study and setting it up, you want to have everybody going through the same thing. So the backgrounds are all the same. Now, between studies, there will be differences. And I think a perfect example is the early information that we have that shows cardiovascular disease is worse with Lupron versus Firmagon or Orgolilix. And I think the issue there is there are no side-by-side comparisons. The data is very early, and I don't think that statistically it's appropriate to make those kind of comparisons. While there may be issues there, I don't think we can say it's proven. And I think that's what we have to look here when someone says that there's a rare increase. You need tens of thousands of people to confirm that in a study, and no one can afford to do the studies to get us the answer on some of these very rare side effects.
Yeah, thank you. But again, we'd encourage you to look at the non-pharmaceutical solutions because there are issues with all the pharmaceutical solutions. There's always going to be a side effect you don't like the look of. So try the non-pharmaceutical ones and then fall back onto the pharmaceutical ones if you're still not getting any relief.
Rick, I have
thank you.
I have a question for John McPhee. You said you got a 4-month Lupron shot. Did they tell you how long they want you on Lupron?
2 years.
2 years. Okay. That's good.
Yeah.
The drug that they prescribed was CYPROTERONE.
Cyproterone. Yeah. Yeah, that's right. You guys have that in Canada. That's not approved here in the US.
Okay, I didn't.
What's the drug, Len?
Cyproterone. I'll put it in the chat.
It's a progesterone-like drug. It's a synthetic drug that acts like progesterone, and it's used in some birth control pills in Europe. And I don't know if it's in a birth control in Canada, but it's certainly used in Europe.
Okay.
You know, Rick, Tony up in Toronto was prescribed that for hot flashes, according to Marguerite.
Okay. Did it work for him?
Apparently, I mean, he was taking it for years.
Okay. So, you know, it may work. That may work for you. You might want to try it, Les, and we can tie Les. Excuse me, John. What we can do is connect you to somebody who's used it up in Toronto, if you'd like us to do that.
If you would, please.
Okay. So be sure to give us your contact details, your email address, and your phone number, and we'll pass it on to Marguerite and Tony, and one of them will give you a buzz and tell you what their experience has been.
Thank you.
Okay, so with that said, I think we should move on to our question, our people who need time. I see that there's Carl has put a significant issue in the chat window. And I think it's probably of interest to everybody, not for the drug that Carl's talking about, but by and large, it's an interesting topic, which is that some of these Part D drugs are changing and the coverage is changing. So Carl, for those who didn't see it in the chat window, why don't you talk about your issue, and then maybe Dr. Mark can talk about one solution and other people can chime in.
Sure. So a few days before the end of the year, I received a letter from Optum Rx, which is the pharmacy that I receive my my cancer medication. And it said that olaparib, aka Lynparza, will no longer be part of their formulary, and that I would have to pay full price. So I haven't been paying anything for the past, it's almost 2 years now that I've been on the medication. And I believe Medicare says that you have to at least give 30 days prior notice, so it wasn't 30 days. But the retail price for that particular medication is somewhere between $13,000 and $16,000 a month. AstraZeneca is the producer of the medication. I did contact them. They do have a program for people if your income, it says joint income is less than 82,000, that they have a program where they provide the medication for free. So I have some options which I haven't pursued yet, because my oncologist is also going to be writing a letter to Optum Rx to try and get dispensation for me to continue on the medication at no cost.
Do they have any PARP inhibitors on their formulary?
I'm not aware. They just sent me a letter specifically of the medications that I'm taking and are no longer going to be covered, so I don't know.
Have you talked to them?
I have not.
Well, you know, the first thing I think I would do is pick up the phone and say, hey, this is an FDA approved drug for my condition. It's not on your formulary. What am I supposed to do? I mean, that would be my starting point. It's hard for me to understand why it's not in their formulary, because it is an FDA approved drug. If it isn't, then I'm not sure of the rules here. Maybe somebody can help me.
What I know is about formularies. I did a little work with consulting with pharma companies. Is the formularies will pick one drug out of the ones that work for a certain condition, and then they can bargain hard to get lower prices for that. So I'd be surprised if there wasn't a different drug on the formulary that covers this. So I would definitely give them a call and see what's up.
Is there another PARP inhibitor?
There are 4 PARP inhibitors, at least that I'm aware of. There are 4 different PARP inhibitors right now.
They probably picked one. I agree with John. I bet they picked one and they're going to pay for that.
Now, the difference is that the strengths are different. The least potent is olaparib. What we seem to think, and there's been a bunch of work and discussion about this with the PARP inhibitors, is that when the PARP inhibitor begins to stop working, switching to a different PARP inhibitor will not help. That said, Professor Bill, God rest his soul, was of the opinion that it could help, and he was a PARP inhibitor researcher. But I've heard other PARP inhibitor researchers and physicians say they don't think that going from a less potent to a more potent will make a difference. But we don't know. It's not been trialed, at least as far as we know. Certainly, it hasn't been trialed in prostate cancer. It may have been trialed in other cancers that feature BRCA mutations. Anybody else want to add anything to this discussion?
Just one more thing. If there isn't another drug that is similar, you should petition them and say that it's medically necessary. And it's a pain in the neck, but it usually will work if your doctor says it's medically necessary and nothing else is possible to be used instead of it.
Right, and I guess that's why I haven't contacted them myself, because I know that my oncologist is on the case on my behalf. But I'll be glad to call them as you suggest as well.
Yeah, I mean, I think I would get a little more information. I cannot believe that there is no PARP inhibitor there has to be a PARP inhibitor in their formulary. You can also look at you can also go online and look at the formulary in your Medicare, in your insurance. It's right there on your computer, and you can see what they are offering as a PARP inhibitor. The other ones are rucaparib, which is Rubraca, talazoparib, which I just can't remember the commercial name of that right now. Anybody remember the name of talazoparib?
Maybe Talapro, I'm not sure.
Something like that, yeah. Talazoparib, rucaparib, niraparib, which is the one that Johnson & Johnson Janssen supplies, and I forget the name of that, but there's about 4 or 5 of them.
Oh, talazoparib is Talzenna, Talzenna.
Thanks. Yep. So you'll find them. The other thing I wanted to mention on this is that I had at least one person come to me, somebody on the call right now, and said, "Oh, what am I going to do? Lupron's going to cost me an arm and a leg under Part D." Lupron is not usually a Part D drug unless you get it from the pharmacy because maybe you're going away somewhere and you want to take it with you. But when Lupron is administered, and any of the LHRH drugs are administered in a doctor's office, it's not considered to be a Part D drug. And that can also be true of other drugs that are injected or infused. So just commenting. And Mark, Dr. Mark says Zejula in the chat window. Yeah, Zejula, is that niraparib? Dr. Mark? Don't know. Okay, but yeah, Zejula was one of the ones that I mentioned. I think it might be niraparib, but I'm not certain. Okay. Anything else on this, or can we move on? Peter Kafka.
One just quick final thought on that. I just sent out a part of an email. Women use olaparib quite a bit for BRCA mutations, and if women are affected by this change in insurance, the insurance will hear about it pretty fast. They seem to have a stronger voice than we do. The thing I wanted to bring up is that I got backed into using Eligard a month ago in exchange for Lupron. I've been on and off Lupron for 6 years, and I monitor my reactions pretty closely, and I've noticed one big change in memory. It's affected my memory, and everything else is the same. I've been on other drugs for quite a while, but as soon as I got on Eligard, it affected my memory, and it also affected my stamina. I have to now take naps for about 20 minutes a day, and I was good for a year or more, tolerating Lupron very well. So I just want to throw that out, whether anybody else has noticed the difference between. Everybody says Lupron and Eligard are the same, but I sure noticed a big difference.
What has your testosterone been doing as a result? Are there any changes in your testosterone levels?
No, that's all less than 4.
Right the way through. It doesn't matter what you were on.
Right.
Okay.
Yeah. Hey, Peter, it's Dennis. I had the same experience. I was on Lupron 4.5 years, and then I had my first Eligard injection a couple months ago, and I could tell the difference. Hot flashes came back, a little more fatigue.
Dr. Mark, why should that be?
My suspicion is that one may be getting a lower level of testosterone with one than the other. But a lot of times when you say you're getting Lupron, you're getting Luprolide, and it may be a generic Luprolide. And there can be variations between one or another, but they're both Luprolide. And the only thing I can say is that if you're more adherent to the scheduling and not going over the 28 days, it's not a 30 days or 31. It shouldn't be on a monthly schedule. It should be on a 28-day schedule or a 30-day schedule and not extending beyond that. The effect should be the same. It's really, I would think for the same testosterone level, how you're feeling is the same, or should be.
Yeah, I do a 3-month shot.
Anybody else have any input? Dennis, and clearly it's had the same effect for Dennis and for Peter. Anybody else been switched recently from Lupron to another LHRH?
I did at about the 6-month mark, and the first 3.5 months of Lupron were accompanied by Zytiga because of the trial I was on. And I didn't feel any side effects from the LHRHs in general until after about 6 months, 7-month mark. I really had heard that people tolerate it better early on than they do a little bit later, that the side effects are cumulative or can be. And I think that's it for me, because the side effects definitely more noticeable later. As far as the testosterone, I would have thought the Zytiga would bring it down extra low with the androgen blockade. I don't really know. I just know that my testosterone was consistently listed at under 10 every time I got it taken.
But the issue that we have with it is that the symptoms are not only what the testosterone level is, but the effect of that may be cumulative over time. So it may be that you've been on the medication for a longer period, may be equally important with the testosterone level.
Right.
So I can't say.
Well, the bigger question is, when does Lupron come back on market? Does anyone have any insight of the supply issues?
Mm-mm.
Yeah.
I have not heard anything about that. I mean, I don't even know. I don't know what was obstructing the supply, but I mean, a call to AbbVie would help. You know, if somebody wants to give AbbVie a call and have a chat with them and just ask them, that would be very helpful for all of us to pursue.
Rick, I heard that it was discontinued entirely, so that would be worth looking into, because I read somewhere that, but I can only say that I read it. I can't remember where.
I just wanted to
Lupron brand name or Leuprolide in general?
Lupron brand name. I heard it was discontinued entirely, but don't quote me. Don't quote me on that.
So there is still the generic version available.
I will call AbbVie.
Okay.
I wanted to mention about the Lynparza and Optum Rx, and Rubraca is level 2 and Zejula is level 2. Talzana is level 3, and Lynparza just has prior authorization. They all require documented diagnosis and reauthorization, but the Rubraca and Zejula are probably going to be easier to get through than the other two.
Oh, thank you for that. Carl, did you get that?
Yes, yeah, thanks.
Yeah,
Okay.
Rick, the other thing I would say is that I've only had Lupron once, and I've been on Trelstar. And compared to what some people tell me about the side effects they experience with Lupron, Trelstar I've found has driven my testosterone to non-detectable, and just my own body chemistry, I'm able to put up with it fairly easily. So that might be an option.
Okay, so again, we've always said as advocates that you can switch between these LHRH because they do affect different people differently. We don't really understand why, but that's another alternative. Not to get another shot in Eligard, to ask if they don't have Lupron, ask for Trelstar. Peter, what were you saying were the two main things? Fatigue and brain fog, was that it?
Yes, those are the two that I experienced. A marked difference right away. I will call AbbVie up though.
Okay, well, thank you for volunteering. We got a bunch of people, so I'd like to move along unless anybody's got anything urgent that they want to add to this discussion. It's a good discussion because it affects almost everybody on this call. Okay, why don't we go, let's go to Mark Finn, because Mark, I know that you were, you couldn't stay till the end, and for those of you who don't remember Mark's background, one of the most interesting aspects of Mark's current treatment is that he's using low-dose abiraterone with food. So, which unfortunately may not be working that well any longer, but you've been on that for quite a long time, haven't you, Mark?
Yeah, just as a quick summary, and Rick, I'm sure you'll keep me to being quick, is that I had a prostatectomy about 5 years ago, followed by chemo. I've been on ADT, except for a short vacation. I've been on ADT since then. And I have metastatic stage 4 disease, but I've had that since the beginning. I did have about a year and a half ago, I had SBRT on one tumor on my T6. And eventually my PSA was starting to creep back up, so I went on a low dose Zytiga with prednisone, particularly because the study that was referenced showed that the overall titer in your bloodstream was not much different between the two different versus taking 1,000 milligrams, a day. And so actually I've been able to, not really feel a lot of side effects from the Zytiga versus many of my friends who are on Zytiga who have the 1,000 milligrams. I feel like they have a lot more fatigue or experience a lot more fatigue than I do. My PSA has now been creeping back up, so I've probably had about a year on Zytiga, and now I've kind of run my path. So I think that's probably typical of people in my case. Whether or not my low dose had anything to do with that, I don't know. So I will now be looking at what the next stage is. There's some options with clinical study, which kind of combines Xtandi and also I don't know the exact, I don't have the study in front of me, a PSMA inhibitor kind of drug. So I'll be looking at that versus, I had a PET scan today, which interestingly enough, I had the PET scan at 11 o'clock and I had the results by 3. So it's really quite amazing. But I still do continue to have some additional tumors or lesions on my spine, the thoracic spine, and a couple other places. So we'll have to decide whether I'm in that sort of whack-a-mole situation of trying to do additional SBRTs or go on to something that's more systemic, kind of an approach to try to see what we can do against these additional tumors. I'll also have to consider. I did have in between then, I had Decipher tested on my initial tumor, and it does show that with my particular genetics of my initial tumor, which may be different than the tumors I have now, it seems that probably ADT will not be as effective for me as versus chemo. So that's one of the things as I decide upon this clinical study, if the PSMA portion of it is part of an ARROW study, if that in fact is more chemo than ADT, then I'm enthusiastic about it. If it's more of a ADT plus, then I'll probably look at whether there's some other things that I want to pursue. Probably short term would be an additional round of chemo with docetaxel, which seemed to work pretty well with me first time. Okay, that's it.
What's your PSA climb to, Mark?
It's about 5.5 now.
Okay.
You know, it's climbed. I mean, I'm definitely in a doubling time of less than 6 months now.
Okay. Who would like to make any suggestions to Mark or make any comments? Maybe let me go to Len and see what's on your mind, Len, with what you hear from Mark.
Well, what I was thinking, Mark, is that just for giggles, I guess, try what Mark Perlow is doing, which I see in the chat box. He's taking 500 milligrams of abiraterone with food. You're taking 250. You know, maybe it'll have an effect, maybe not. Another thing you could try is switching your. I assume you're taking prednisone with the abiraterone.
Yeah.
So if you switch to dexamethasone, in something like 35 to 40% of cases, people who find they're being resistant to Abby plus prednisone switch to dexamethasone, and they get a few more months of success out of the treatment. So talk to your oncologist about that one.
Okay.
That
yeah,
was,
actually, Len, your thought about increasing it, I sort of it's interesting because we were talking earlier about different formularities, and the bottom line is I get my drugs through Express Scripts, and they don't have a script for 250 a day plus prednisone. So they send me a script for like 400,000 a day plus plus prednisone. So I end up getting all these Zytigas, which I haven't been taking. So I have been self-medicating a couple of times where I've gone for a couple of months of actually increasing my Zytiga up to, not the 500, but up to, well, yes, the 500 plus 5 milligrams of prednisone. It didn't make any difference. So when I talked to my oncologist, told myself medicating, he said, well, nice try, but I wouldn't expect a change. And in fact, I didn't have one. But that's a good suggestion, Mike.
Mark, I think Len wrote a blog post on switching the steroids. Did you not, Len?
I believe I did. It was maybe a year ago. Have you ever searched our blogs, Mark, Finn?
No, I have not, and I will explore whether dexamethasone might be another option.
Right. There are studies on that because I know that Len quoted them, and I'm pretty certain there. If you just put in steroids, I think on the blog post on the search, it probably is going to pop up. Okay. Anybody else have any comments that they'd like to make to Mark? Yes.
Well, I mean, I think given that you had, and I assume that the docetaxel was successful, that it.
Yeah.
So I would say maybe a Taxol would also be in order here. I mean, not so much docetaxel, but maybe a carboxytaxel, which is supposedly a little less onerous.
Well, that's a great suggestion, and that's something I already talked to my. Actually, I talked to the urologist on my team, not my oncologist, but that's one of the comments I had is, should I change drugs? I think the decision of my team will be, at this point, do you change it? Or because we did see some drop in PSA and so on after, now you got to remember, I got my chemo immediately after my prostatectomy. So was it the prostatectomy? Was it the chemo? It's hard to determine. But the docetaxel might have worked. So if it did, do you change or you just go back with the same one? It's a good question, which I haven't resolved yet. But I have posed to them the fact that carboxytaxel, do we try something different?
What was the genetic test that suggested that ADT would not really be effective for you? Because that really is an issue there about whether you want to continue the route of changing abiraterone dosing or steroid dosing. I think if they're showing that there's an ARV7 mutation, that may not be the best way to go to focus on the AV, on that route.
Well, I'd have to pull that up and look at it again. In general, I have the unfortunate situation that I don't have genetic mutations. If so, there would be ARP stuff and other stuff, PRP stuff that I could be taking a look at, but it seems like I am a genetically mutated cancer patient without genetic mutations. So I don't know about that. I had a Decipher test, which again is actually a test they do on the tumor that was removed like 5 years ago. And it just kind of rates different kinds of approaches. And my particular tumor, it tended to say that it said that a most effective way after it might be chemo versus ADT. So that's something I have not presented, but I will be discussing with my oncologist team. Does that mean that, for instance, this clinical study, if it's an ADT plus, well, do we really want to go after that? Or should I just be thinking more of just thinking about doing some additional chemo? In general, I tolerated chemo fairly well. I mean, made a mess of my fingernails and toenails, and I lost my hair, but it worked out all right. I didn't experience a lot of side effects.
Ken Anderson, go ahead.
Yeah, I was just going to add one comment that Paul at MD Anderson had made to me when he decided to initiate the docetaxel re-challenge. And his comment was that if you take, one of the other taxane-based chemos, that you might limit your clinical trial ability. So that would just be a comment or a question you might pose to your doctor, whether or not it, does anything to your trials.
Yep, good point.
All right. Well, we need to keep moving along, but we've certainly thrown out some really good ideas for you, Mark. And
Yeah,
Jake
thank
was
you.
kind enough to post the link to Len's post in the chat window.
Okay.
So you can just click on that and it'll pop up for you.
Yeah, I will just, in closing, it's interesting that, I was talking to my wife after my scan this morning. She says, when we got the results, and I said, well, I don't know, 2 or 3 days, and I'm not talking to my oncologist till next week. And I actually, it might be workload related, but I actually had the results, which seemed to make sense within 3 hours. It was kind of interesting.
Hey, Rick, I just want to comment. I couldn't find my own blog. Maybe it expired if it's too old. But anyway, I found the original paper by De Bono in British Journal of Cancer, and I put that in the chat box, comparing prednisone with dexamethasone.
Okay. All right. Let me just copy and paste the the link so that it becomes live. If I can copy, but I think it is searchable because Jake found it, Len. So
in the blog.
Yes, scroll up. It was from July 19, 2019.
Yeah, it's there, Len. I found it before. Okay. Let's keep moving on. And Terry, I think you were with us the first time a couple of weeks ago. Just remind us of your situation and tell us what's on your mind today.
Yeah, this has been very helpful. Listen to everybody else speak about hormone deprivation therapy and such for me. It kind of answered some of the questions I wanted to ask. Yeah, I had my prostatectomy back at the summer and had some complications. Also had kidney cancer, and they took that out at the same time. The kidney cancer looks like they nipped that in the bud, and I got great kidney function, but the prostate cancer is not nipped in the bud, and that is spread. I had a PET scan, and it has invaded the lymphs. And so I've been discussing and knocking it around with the oncologist, and they want to put me on the hormone deprivation therapy, and I'm getting a real education listening to you guys here. And I try to educate myself, but I get about a half hour into research, and then my anxiety and depression and everything takes over, and I have to go do something else. So listening to you guys, I'm getting a lot of information here. I'm at Oregon Health Science University here in Portland, and the doctors, the teams there have been great too, in keeping me informed, educated, and learning more. So, and I've just been kicking it around because in October, when they did my PSA, it was 1.1. And then in November, they did it a month later, it was 2.1. And so that's rapidly rising. And with the PET scan, it showed that it had gotten out. It's in the pelvic floor and it's in the lymph glands. So they're going to put me on this hormone therapy. I didn't like the first oncologist because he just wanted to hit me up with something that lasts 6 months. And I got a second opinion, and the second oncologist, Dr. Buki, I think I mentioned her last time. You said you knew her. She's going to go ahead and start me on stuff where I can try it out for a month at a time and see how it works out. With it rising so fast, just following surgery and such, they pretty much assured me I'm going to die of cancer before I die of something else, because I'm pretty damn healthy otherwise.
Who assured you of that?
Well, just talking with the doctor, because it's metastasized and it's gone so fast, and so it's like.
Let's talk a little bit about that, because it always bothers me, and it may be your interpretation, and maybe you're putting a spin on this. So you can manage metastatic prostate cancer for quite a long time. We don't really know why some people have no luck and they go quickly, and other people can manage it for years and years and years. But you've got probably an assortment of guys on this call, some of whom have been managing it for a very long time, and will probably or may well pass from something else. So right. I don't want you to go off this call thinking, oh, this cancer is going to kill me, but you have to get with the program. And unfortunately, the program requires hormone therapy, at least to begin with. Maybe after a year or 2 years, you can come off it for a while. But to start off with, there's no getting away from the fact that the hormone therapy is the gold standard. What else they add to it is really up to your doc. Anybody else want to add any words of encouragement or foresight to help Terry deal with this?
Terry, this is Al Latimer. Last month, I just had my 25th anniversary of my radical prostatectomy, and I found out at that time that it had already spread to my lymph nodes. So one way or another, I've been doing this for 25 years, and I am still here. So it isn't a death sentence, I would say.
Yeah. I just was pretty rattled about the PSA rising so fast. I'll be getting another one at the end of the month, and to see where it's at. And then I will be making the decision on moving forward on the therapy. And I'm sure I'm going to do it. I'm just very reluctant. I'm really not pro Western medicine. My doctors already assured me I made the best, decision I could by getting the prostatectomy in the first place. And I've done the most I can to stop it by doing that alone. Obviously it wasn't enough.
So Terry, I want you to listen to Jim Barnes.
Okay.
Because I remember about, is it 6 months ago now, Mr. Barnes? We had similar conversations with you. Do you want to share your wisdom with Terry? You're muted right now, Jim.
Sure. I mean, when you first get the news, you're really freaked out, and then you learn different ways to, in order to manage it. And you hear people like Alfred. I was just amazed at what he just said. He's been managing it for 25 years. So it's a matter of just, just taking day by day, enjoying each day, not getting too down about it as much as you can, and just staying with it. And my head is in such a better place than it was 6 months ago by just doing that and realizing it's a management process.
So you just started yourself, huh, James?
Right. I just completed treatments of radiation. I didn't do surgery. I just went for radiation, and just scheduled my radiation for my back in February.
Okay, so you're getting a lot of radiation. Now that will be my next. They'll have to hormone therapy and then radiate too. Is the next step. They want to shrink down what's there and then hit it with the, as they kind of said, we're going to do the deprivation. Like, think of it as a weed. You're not watering it, and then you're going to hit it with weed killer with the radiation. So, what are the side effects of the radiation that you're experiencing?
So again, I didn't have surgery. I just purely had radiation. So it's just discomfort and urination, and a little bit of bowel discomfort or little minor side effects there, but it's really no other side effects other than that.
Okay.
So my radiation situation is a little different than yours because you already had surgery, right?
Yeah, there's going to be a whole different. I'll want to talk with others who have had their had targeted after having hormone deprivation. Yeah.
Right.
So Peter, you had surgery. Oh, John, one of you two guys, John or Peter or both of you, talk about getting some surgery afterwards, and also both of you and Jim, you're all on at least one level of hormone therapy, if not 2 levels of hormone therapy. So, John, you go first, and then Peter.
I'm kind of a newcomer like you.
Yeah.
And after I had my surgery, my PSA tripled between 6 weeks after the surgery and 12 weeks after the surgery.
Oh boy.
This put me into a mental state like yours, because I heard that doubling time and tripling time were really important.
Yeah.
So I figured it's wildly out of control and there's no stopping it.
Yeah.
So I got started on hormone therapy, and a couple of months later it had knocked it down to half of what it was. It didn't cure me. It didn't make it go down to 0, but it completely stopped it in its tracks.
Okay.
So I would encourage you to do whatever it takes to stop it in its tracks. That's exactly how it worked with me. Then after a little while, they did radiation therapy.
Yeah.
And then I got another PSA, and it divided itself into 3. So
Okay.
it's still not 0, but it's going down. So I just, I don't know how long I'm going to live either. I avoid asking the question of these guys and of my doctors, but I can tell you from my first year in this, the treatments work, and I think you ought to do them.
Okay. Yeah.
You and I might last a long time.
Yeah, John. I know. Wow. Boy, I'm so glad I joined this group. I needed this, man.
Okay.
What's your Gleason score, Terry?
Yeah. Rick, the piece that I'd like to add, Terry, is that probably to varying degrees, all of us have been in that place. I mean, for me, I'd had urinary issues and bladder issues, and went to find the urologist, and he said, well, we'll check to see about your bladder activity and stuff. And then 6 months later, I went back to my follow-up, and he says, well, you have stage 4 metastatic prostate cancer. It's like,
yeah.
Well, holy shit, how did I go from 0 to 90 miles an hour that quick when I was monitoring this actively?
Yeah.
So,
yeah.
but you
Three
just
years I got checked for Flomax, and my PSA was normal. Yeah.
Yeah, but I've been at this for 5 years, and this group and other groups you can work with really help you kind of, navigate the whole process. It's not easy, but I would say that, probably, the old thing was that people die with prostate cancer versus dying of it. Probably when you look at this whole group, there's probably more of a likelihood that many of us will die of prostate cancer. But I do think that some of the old paradigms of, only this many years of that and so on, I think we're in a much better place. And, actually, this is a relatively good time to get prostate cancer because there's a lot of options, and the research and the development is just accelerating all the time. So there's lots of opportunities. So keep the faith.
I will. I am. Thank you.
Yeah, so the only thing I would add is, Terry, so I'm entering just about my 6th month, and I started out with stage 4 metastatic as well, and the same thing, 0 to 90, totally freaked out. Thought it was COVID, and it turned out, of course, to be this, and it was a rigmarole to figure out what it was. And I went from like 740 PSA, and then within 30 days, I was down to less than 2.
Wow.
So you don't know how you're going to react to it, and I'm so grateful that that's how I reacted to it. But that doesn't mean my mindset has changed. I still get freaked out all the time as to, how long am I going to be lucky enough to have this treatment work for me that well? And then, and what else is going to happen? And it's really a roller coaster. I mean, I've found that, like, with the medicine, I had lost a lot of weight because I was trying to lose weight, and now I'm like, it's like an air pump has been hooked up to me, and I'm like gaining weight like crazy. So now I'm back on the other end trying to get my mindset to like get back down and get healthy and to help the body stay healthy. So I'm with you. I understand. The mind just kind of travels and runs, and it's just a journey you have to take.
I get locked in this place sometimes, like, oh, do I want to die of prostate cancer and have all the complications associated with treatment, or just die of the cancer? And because I've had a great run. I've enjoyed my life. I've left beautiful children on this planet who are responsible, and way more responsible than their old man. So, like, I don't know. Does it?
Hey, Terry. I remember you were on a few weeks ago. You were also the same thing. You were pretty freaked out about it.
Yeah.
But I will tell you, the quicker you get on the ADT, your PSA will drop and you'll feel a lot better. So rather than just ruminating in the fear, get on the ADT. It really isn't bad at all. I was shitting in my own pants about it, and I purposely didn't go on it for a long time, and I think I hurt myself by not doing that. Don't make the same mistake. It really isn't bad at all, and you've got many, many years ahead of you, and it really is not bad. We're all on it, and we're all living fine.
You seem great. I know. I'm looking at you guys, and I'm like, well, these guys are just dudes. They don't seem debilitated from any of the treatments.
No.
So you're giving me a lot of encouragement and faith here. I'm rattled. I just got hooked up with a therapist too. So
good. That's
going to help, because my primary care physician that I saw last week was a bit worried about my head, where it's at. My second opinion oncologist, Dr. Vuki, who I'm going to keep, and I see in a couple of weeks, in another 2 weeks. And she's going to get me on track with the hormone therapy. In the meantime, since I got the news that my PSA was existent back in October, I went on a very high dose of Rick Simpson oil. So I'll give you guys a report on that, on how that worked, if that brought it down at all, because there is some evidence that it can.
Not really. I mean, we've been talking about this for a long, long time, and we do not. There is no evidence at all that any type of CBD treatment is effective
It's not CBD, it's THC.
Well, let's say any type of marijuana treatment is effective in a curative sense. It's very, very helpful palliatively, and we strongly recommend it for palliative, but there is no evidence at all. And to look through our website, we've done webinars on this, we've talked about it frequently, and I'm saying this to you in no uncertain terms because I don't want you to get your hopes up on it.
I'm not considering it a silver bullet at all, but in the meantime, I'm using it. When I got the news that I had a 27 PSA last October, I began using it, and I brought it down to 19 with the addition of Rick Simpson oil and diet and exercise.
Well, I think what we would say is it was the diet and exercise that brought it down rather than the Rick Simpson oil. But if it helps your head, God bless you.
And I'm gonna, I don't consider it a silver bullet. And in fact, if it does nothing at all, it sure helps me sleep real well.
Exactly. And that is huge. We definitely, so we're much in favor from that standpoint. Let me just say, because we must move on, a couple of things. We have, and it's in the chat window, we have our own group to discuss the sort of issues you've been talking about called Men Speaking Freely. This month's meeting will be on the 21st of Jan, and we would encourage you greatly to attend that. I don't think Rusty's on anymore. He was, but I think he left. And he's one of the moderators, and there are a couple of others, and it is a fantastic session. So think about that. And just keep coming back every week. We're here for you, and we'll give you the encouragement on a weekly basis. And if you need more than that, reach out to us. We'll find people in your neighborhood or people on this call who will talk to you offline.
Thanks. Thank you, Rick. I appreciate all you guys' help and input. I really do. I'll be back. I might drop out here real soon though, but I got to eat dinner.
Okay. Now, we had a bunch of 30-second merchants, as I recall. So I'm going to go and knock off some of these 30-second merchants as quickly as I can. And I'm going to start with Len, because I remember he was a 30-second merchant.
Okay, start the clock, Rusty. My PSA down here in Florida was less than 0.06. That is their limit of detection. Up in New York, the last PSA I had was 0.03. So I'm somewhere between 0.03 and less than 0.06. Done.
Okay, so you are somewhere between 0.03 and 0.06, but 0.06 is the lowest, the lowest the test goes where you are, right?
Correct.
Okay. All right. Well, let us just say we're delighted that you're at that level, especially since this is solely from darolutamide monotherapy. You're not on an LHRH right now. Is that true?
That is very true. I haven't had LHRH since May of 2020.
Fantastic. Okay. So, any questions, or can we move on to our next 30-second merchant?
Congrats, Len.
Yeah, it's awesome.
Awesome. We love it, Len. We love it. All right. Now, let me think. Who else told me they only
I had a question for Len. How's it feel to be off the ADT?
Oh, feels good. You know, my T level is at 250. The brain is working better. Fatigue is diminished from where it was when I was on LHRH and darolutamide. So it's all good.
Okay. All right. Who else said that they only needed 30 or 40 seconds? Somebody said 40. Oh, David Maslin, you're okay. 40.
All right, you can hear me now, can't you?
We can hear you now, yes.
Okay, so when I left Chicago in November, my PSA was 0.04 at Northwestern, and I just had a Quest lab done down here in South Florida, and it came back at 0.1, but no digits after the 1. So I'm assuming maybe they don't go lower than 0.01. Any thoughts there?
Yeah, I've had testing at Quest, and I only had those 2 digits as well. If all their labs are the same.
Well, I think
right.
You have to ask for an if you want it lower, you've got to ask for an ultra-sensitive test.
Okay.
I think different code. I don't know. Dr. Mark, you're nodding your head. Is it a different code, the ultra-sensitive to the regular?
Yes, it is. They have separate codes for each. so far I haven't had any problems getting it paid for. I go through LabCorp, but it is very definitely the right code. One time tech got the wrong code. My doc made me go back and order again. So yeah, be careful on the codes.
Got it. Got
I
it.
think Quest
Okay.
calls it a post-prostatectomy PSA.
Okay. But you'll just tell them you need the ultra sensitive, David, and give us a report next week.
That's what I assume we'll do, boys. Thank you. 40 seconds, I wasn't counting.
We asked you a question, so you got taken off the hook. Who else was that? Who else said they didn't need a lot of time? They were just going to give us a report. Was that you, Ken Anderson? Didn't you say you were just going to give us a report?
That was me.
Okay.
Yeah, I just finished my 11th round of chemo and got labs, which include that. But more importantly, you know, I did go 45 days ago, I dropped Lupron, and my PSA is holding at about 2.5 just on Zytiga. So I think monotherapy, and I do feel a difference not having both drugs in my system. So
you're on,
yeah,
you're just on abiraterone right now, is that right, Ken?
20.18. In that regards, I'm pretty happy about it, but PSA dropped 8 to 17.1. My testosterone rose on 11/6. It was at 4, and then not sure why it went up, but at the same time, my PSA was going up and my alk-phosphate was going up on the graph. So they run pretty parallel, you know, as they rise and drop. So after that, anyway, I saw my PSA drop and the alk-phosphate drop 58 to 48. So right now my testosterone is 2.5, PSA is 17.1. So pretty happy with the results. And that was after 4 weeks. And the typical cycle for docetaxel is every 3 weeks. And Paul has said, go ahead and try 4 weeks. And so after 4 weeks, I still got a drop. But I did notice the last week the chemo had wore off because a couple of the side effects that I have, like teary eye, disappeared. So
okay,
that's my story. That's it.
That's your story. Anybody want to talk to Ken about just being on Zytiga monotherapy and not being on the LHRH?
I have a question about that abiraterone. You know, when I was first in this, the story was that abiraterone just took care of that few percentages of testosterone that came from the adrenal. But as the months have gone on, I've heard people talk more and more about it as having a broader effect, maybe against a lot of different steroids. And now I'm hearing about abiraterone as a monotherapy. Can somebody catch me up to just what that drug does, please?
It's okay, Larry. It's a CYP17A inhibitor. I know that doesn't mean anything, but what it does is it blocks all steroid synthesis. So theoretically, it should work as monotherapy. That it should actually prevent steroid synthesis everywhere the drug gets.
I think that's true because the beginning of the year when I was not on abiraterone, my T level was running. In fact, my testosterone on January 6th of 2020 was 24. That was on Lupron. And as soon as I got on Lupron, the next, 3 months later on 3/6, it had dropped to below 1. So abiraterone is definitely a stronger drug. And Paul's comment was he wasn't sure at MD Anderson, but he said try it. And he thought that it was a reasonable approach. Actually, and I think it's working well because I'm happy not having Lupron in my system as well.
Ken, this is Jake. Does Paul think the abiraterone or the docetaxel was having the effect? Or both?
Oh, no, it's definitely, as far as lowering my T levels, abiraterone.
Right, T levels.
Docetaxel, yeah, docetaxel is as you know, Dick, 1 month you get a really big drop and the next month you get a modest drop. The biggest drop I had was on PSA was, I don't know, I started in July at 41.3, and at the end of the year I'm at 17.1. So I don't know. I think it's a reasonable approach as long as you can handle docetaxel.
Yeah.
So I'm going over my 30 seconds.
I think saying that you're on monotherapy with abiraterone is a misnomer. I think it's, you're abiraterone and docetaxel.
No, Jake, that's not true.
Oh, correct me.
So I'm on both drugs, but abiraterone's definitely the one that's dropping my T levels. Chemo is not.
The T levels, but docetaxel is what's dropping your PSA.
Correct.
Yeah. So it's not a monotherapy is what I'm saying. That's all.
Oh, I got you. For androgen deprivation, for blocking the ARBs, I don't consider docetaxel the same. So those are two different approaches and they do two different things. Is that a true statement or do you guys agree?
Who wants to dive in here?
Well, they're apples and oranges. I mean, I agree with Ken. They're apples and oranges, right? They both
I don't know.
affect tumor progression through very different mechanisms.
Yeah.
I think I hear both sides. I think that when we talk about monotherapy, abiraterone or darolutamide, we're usually thinking of it in terms of being the single treatment. The fact that Ken is on chemo along with it doesn't mean it's truly comparable with other people that have done monotherapy abiraterone, but from Ken's standpoint, it's the only hormone agent that he's taking. So we're sort of, to some extent, splitting hairs, but I will agree with Jake that we don't know what's causing the drop in testosterone in PSA. It could be the docetaxel killing the cells, or it could be the abiraterone, which is starving the cells, but we don't know.
Are you going to continue the docetaxel, Ken?
You're going
to go for round
I put that question to Paul. I'm way over my 30 seconds, but I put that question to Paul, when do I stop? And he said when it stops working. Or when the side effects are so great that I can't handle them. So I don't know. I'm going to continue doing it at the moment. I have in my head at least, 15 rounds. So I'm going to do 12 when I return, and I'll do 3 more. So that's where I'm at the moment. It's buying me a year. So.
All right. Well, look, we've got 15 minutes left, and we've got 4 guys to visit with. I believe Vern, Frank, Jimmy, and Al. So let's start, and we will get around to all of you, even if we have to go over the 8 o'clock hour. Let's start with Jimmy. Go ahead, Jimmy.
Good. I'll be quick. Unlike those other quick guys, who I really enjoyed hearing from. I got in touch with Joe Gallo, like you recommended, Rick. I sent him an email. He emailed me back after I asked him if he got my email, said he didn't get it, but he was sorry. So I forwarded it to him and he's working on it. So the second opinion is still, still floating. And in the meantime, I'm just, last Lupron shot was, the Eligard shot was in September. My wife got me this new chair for Christmas present. It's a gaming chair, the most comfortable chair I've ever owned. And it has a big T on it for testosterone. That's completely coincidence, but we'll see what happens. I'm just still hanging. The only other thing I want to say is, for any of you guys ever had incontinence, I still have it, and I was making a soup tonight, and I had to chop and clean a jalapeno pepper and didn't wash my hands real well afterward. And then I changed my pad, and it was on fire down there. I'm telling you, it was talking to me. It said, "You used to present me with much nicer things than this." So make sure you clean your hands real well if you're a pad changer. That's all I got to say.
And let me just add, even if you're not a pad changer, you should still clean your hands, because
Don't go down there.
I got that T-shirt too. The only thing that's worse than that is when I put in a contact lens and I forgot that I've handled peppers, jalapenos, and that's even worse. Believe me.
I don't know. I'll take your word for it, but it's no fun down in there in your business, especially it's insult to injury, you know.
I know. Listen, man, stay on Joe. He's good. But I don't know what happened there, but stay on Joe. We got to get you that second opinion. And
okay,
there'll
be more to say later about that. So move on, please.
Okay. Al, what's on your mind?
I wanted to report I got a letter today from MD Anderson. It's saying that Dr. Efstathiou is no longer seeing patients. I wanted to know if anyone in the group knew that already.
Did not.
The letter came from Dr. Korn, the head of the department, and it doesn't really explain what's going on. It just says she's no longer seeing patients.
Well, maybe Ken Anderson can do a little bit of prying around when he speaks to Paul in the next few weeks. Here's sometimes what happens. These guys these docs that have significant research commitments only see a limited number of patients, and it may just mean that her patient load is full because a lot of people like her, and she just is not taking any more clinical patients because of her research. Ken, you want to say something?
Yeah, it's probably they are gearing up for clinical trials. So she's probably going to be in charge of a trial. So she has to get rid of some workload. I'm not seeing it, of course, from Paul, but I can only say if the letter's from Paul, I'd ask to see if he can be your doctor. See if he has time to
yes,
take her place.
Yeah, that's what I'm going to try to do. It doesn't say she's not taking new patients. It's saying that she's not seeing patients, period, coming January 1st of this year. So
well, maybe,
I guess
maybe she took a
leaving.
place
Maybe
else.
it doesn't say she's leaving MD Anderson either. So anyway, I just wanted to report that this letter came today.
We can drop her a line and ask her. I think we've got her email. I'm not sure because we interviewed her last year, as you remember. But I think that if we leave it with Ken, he'll do a little bit of prying around when he speaks to Paul, and we'll get back.
Yeah, the next meeting I'll know. So just come to the next meeting on Tuesday.
Okay, and yeah. Al, what I would say to you is ask Dr. Korn if he can see you, because you can't go wrong with Paul. He's great.
Yes, well, you originally recommended either one of them, and she had the first appointment. So I did have a Zoom appointment with her back in late November, early December, I guess. And she has gotten me PSMA PET scan appointment at UCLA, which I'm going to go to in February.
Oh, that's good news. I think, is that good news? It sounds it.
Well, if I get my vaccine before I go, it'll be better news.
Okay. Okay. Yeah, we don't want to keep you alive for 25 years and then lose you to COVID. That would be criminal.
That would suck.
Okay. All right. anything else or any other suggestions for Al in terms of treatment options at MD Anderson?
I have a question on the PSMA at UCLA. Is that part of another clinical trial, or is that part of the FDA approval? And who's paying for it? Is your insurance paying for it?
Well, the insurance issue is still up in the air. It has, if I'm going to do it regardless, if insurance covers it, by the time I go, then fine. If it doesn't, I think I'm going to do it anyway. We'll see. It's still 2 months away at this point.
All right.
Al, did you get a letter? Did you get a letter from Mark Schultz about their change in policy? I
did. Yes. So yeah, for the Zoom calls, we become members now. Yes, I did get that. I did get that email, and I guess we don't have much choice, do we, Peter? We just have to do it.
No, I think they're back against the wall there. Yeah.
Okay, Peter, since you raised it, do you want to tell everybody else what you're talking about?
I put something in the chat window earlier. I think there's going to be changes this year in Medicare and private insurance companies and hospital rates and all kinds of stuff, because we're not going to get through this pandemic thing without some collateral damage. So Schultz's office, prostate oncology specialists, they're not getting, when they went to virtual calls, and over half their patients now have virtual consultations, and they're not getting reimbursed the way they used to. So they've gone to a model now where they ask existing patients to chip in $250 to become a member. They went to a membership type of thing. So once a year, or at least this year, $250 to beef up their coverage for a year's worth of consultations. And new patients will pay about $400 or $450, something like that.
Peter, do you have an idea or did you clearly understand the option 1, 2, and 3 about paying and submitting and them trying to cover the cost on it? I wasn't entirely clear on what they were saying there.
They've done that forever. I always choose option 1. Put it on Medicare first, then go to the other ones.
Yeah, that's what I chose, but I just wasn't clear that that's what they were saying.
Yeah, I think that's just the way they work. But that's different than this $250 membership fee.
Okay, I'm going to jump in because we've still got Vern and Frank. So Vern, you first, and Frank, you get the wooden spoon tonight. Somebody has to get it. Sorry.
Hi.
Vern, please go ahead.
I have an appointment next week with Dr. Singh at Mayo Clinic to go over newly metastasized cancer. And if anybody has any comments about Dr. Singh, I'd like to hear them, or you could email me.
So yes, we have some people. Dennis is on, Jerry's on. I think, is Jerry still on? Maybe he isn't. But Dennis, why don't you start? Oh, yes, both of you are there. First, Dennis, and then Jerry, talk about Dr. Singh.
Oh, what is there to say about Dr. Singh? He been taking care of me since I was initially diagnosed stage 4 metastatic about almost 5 years ago. And I've stayed with him. He changed positions. He went up to Mayo Clinic. He used to be down here in Tucson at U of A Cancer Center. And I just had a lot of respect for him. He's done a good job, I think, with me. He can be a little bit difficult to understand sometimes with a strong accent. But when you have a question or an issue, he gets back to you. You could connect through the portal with Mayo if you have any questions about anything, and he usually gets or one of his staff will get back to you.
Okay, thanks, Dennis.
Jerry?
There's not much more I can add to Dennis, except that Singh met me when I had my first appointment after, as a matter of fact, he diagnosed me. Gleason 9, again, metastatic all the way up the spine, T4, and but he set me up. His protocol was perfect for me. And like Dennis said, I don't find him really hard to understand at all, but he can be thinking about something else maybe a little bit, but he'll stop and he'll answer all your questions. And Dennis is right. The Mayo portal, I just love. I just, sometimes when I'm reading research, I get, some paper and get off on a bad angle. But I just asked him a pharmaceutical question about tramadol, because I've been using tramadol for about a year and a half, and I had read that it affects your mitochondria. So good night. Let's see, Saturday, I put it in my portal. Monday morning, a doctor of pharmacology answered my question. So you don't, he's right on top of it. And like Dennis said, one of his nurses will answer you if he doesn't. That's it.
Hey, thanks, Jerry.
I'd recommend him to anyone.
Thanks, Jerry.
So Vern, one thing that I would say, we say this to everybody, it's really important. Take a list of questions in with you and hand that list to Dr. Singh. Keep a copy for yourself and give a copy to Dr. Singh. Or you can put them in your patient portal a day before. But make sure he has a copy of your questions. That way, all of your questions will get answered. If you go in just holding that copy yourself, there's a good chance some doctors skip over questions. But if it's part of your patient record, they will address every question on that list. Is that true, Dr. Mark?
Yes. Oops.
So it's a little trick. It's, a lot of people say, oh yeah, I always take questions. And we say, well, do you give the doctor a copy? No. Well,
and I say to get it there about 2 or 3 days beforehand to let them know what you're going to want to talk about. You may not get to all of them, but it does help them prepare and at least look at your record to get information that they would need to answer the question. So I've started, after you said that, I've started using that with all my patients too, suggesting them to prepare questions first and let me see them.
Yeah, and let me just say that we've been using this for a long time and we know it works. But please don't put in more than, we say 10, but if you can make it less, even better, 6 questions maybe. Don't take advantage of it. Try and get your questions down to a limited number. If there's some stuff that's less important, you can send it in later in the portal. As you've heard, Dr. Singh or the Mayo staff are really good at responding. But just try, be respectful of their time, but make sure you put the most important things in and you hand them a copy, and then you'll get everything answered. It does work. I really want to move on to Frank, who's been very patient, and thank you for hanging in there, Frank.
Sure. I was on my appointment last week. I took your recommendation back to my oncologist at the James. I have the 3 nodules in my lungs, and I passed on to him. They have been on 3 months of Firmagon injections,
and my PSA has gone from 2.82 down to 0.69, and my testosterone has gone from 298 to 15. So I said he was recommending that I start chemo with docetaxel, and I said to him I would prefer to have a CT scan first, and with the reduction in PSA and testosterone, and see if the nodules have decreased in size since September. I had the CT scan last Tuesday, and the nodules have stayed the same size. They haven't increased, they haven't decreased. So he pulled the string and said, okay, we're starting, as long as you agree, we're starting chemo on this week on January the 7th. And he scheduled me for 6 treatments, 21 days apart. He has me on dexamethasone 2 the evening before, 1 in the morning. And that's going to start on Thursday. Now, he also said in his plan he wants to start me on apalutamide after the chemo, after the 6 treatments of chemo. I've been reading about the difference between apalutamide versus darolutamide. And I'm going to be taking the question to him is why not darolutamide instead of apalutamide? So I wanted to throw that question out. And then the second question is, I know Ken Anderson brought up, is why not, if we go with darolutamide, why not start it at the same time as the chemo?
Right.
So those are the questions that I have.
Okay, so let's focus first of all on the chemo. Since there's several of you that have been on chemo, what words of advice do you have for Frank, who is about to get his first chemotherapy? And why don't I go to Ken on that, since he's had more chemo sessions than I think anybody else on this call. When I say that, I accept Jake, because Jake's on a different schedule, a weekly schedule, and a much lower dose than the normal schedule. But in terms of people that are on, get it once every 3 weeks, I think Ken has had more than anybody. Ken, go ahead.
All right. You know, I can say that the first 6 rounds, and I must admit that was 4 years ago, but the first 6 rounds of docetaxel, you know, the first round I was completely mental and I got the shingles because I was just crazy because I didn't want to do it. But as far as doing the docetaxel cycles themselves, my routine is my routine, and you can take it for what it's worth. I usually drink, you know, a pretty good sized cup of prune juice for stool. And I know the 3rd, 4th, and 5th days are tough days after chemo. So you just plan on staying on the couch for those days.
And
that would be about it.
What about you or anybody else, as you ramp up the doses from the very first one, as you progress? When is it going to hit you? When are you going to feel it? I mean, I do know that most men don't really feel much of an effect after the first dose, but that does, the impact increases as you increase the number of doses. Anybody want to talk to that?
Yes, by number three, you'll be feeling it. It'll take you a week to recover, and then you'll get knocked down again. I took, and on the darolutamide subject, I took darolutamide all the way through my chemo, before, during it, and after. And I also did carboplatin as well. And it knocked me on my ass, but I'm okay now.
Yeah, look how much hair he has now, Frank. Maybe your hair will come. Check it out. And at least you
For
don't have to.
sure.
Yeah, yeah. Les is now thinking about chemo, right, Les? Um, but no, at least you won't have to worry about losing your hair. But anybody else want to say anything on the chemo, and then we'll just touch briefly on the darolutamide or doing two together. Anybody else want to have any suggestions, words of advice? I mean, tips, something, and anything that might help.
All I can add, Rick, is it's all about fatigue. So you have to take your time on, and again, Peter was right. You know, the first couple rounds of chemo of docetaxel, you don't really notice a great deal. I was re-landscaping my house at the time I took the first 4 rounds, but by the 5th round for me, you know, I started to get neuropathy in my feet, and I still have it today. I just take gabapentin and it deals with it. But I mean, you'll notice fatigue, a great deal of fatigue, almost like the flu hits you on the 3rd, 4th, and a little bit on the 5th day. And you just have to plan on being down because you'll be down. You have to be on the sofa doing nothing for the days. But it's doable. You know, it's a chore, but you can do it.
Frank, this is Jake.
We do know, Frank, hold on, Jake, and I'll come to you. We do know that exercise really helps if you can do it. Try and get out, try get your heart rate up, 15 minutes, half an hour, whatever you can do. The more exercise you can do during chemo, the less the side effects and the better you're going to feel. And most everybody will take.
I attest to that for sure. I mean, yesterday I did with Alex, who's another prostate cancer guy in Portland. I did a little mile and a half walk around the town. So definitely, if you can get up and do it, do it.
I'll speak to that anytime, Rick. Anytime. I had no problems with chemo.
Thank you, Jimmy. Jake.
I was just going to say to Frank, not everybody on chemo gets nausea, but some people do. So, you know, you might want to ask your doctor for a low, you know, for a few days worth of nausea medicines. They're usually generic and pretty cheap, but it's good to have them on hand just in case.
Yes, he already provided me with that.
Okay.
Great.
Did he say you're going to give you Neulasta, like the day after?
They'll be doing a blood draw before I start.
Okay, Neulasta is to keep your white blood cells from crashing.
Right.
Yes.
And they usually give you a shot the day after shot, or now they've got a thing that goes on your arm and automatically gives it to you, so you don't have to go back to the doctor's office. That's important. When I got mine about 5 years ago, they weren't prescribing it routinely, and I ended up with white blood cells crashing and ended up in the hospital.
Yeah.
I actually had that same experience.
Yeah.
That basically it was not prescribed routinely, and only after I got neutropenia.
And what was it that you received?
It's called Neulasta.
Neulasta.
Neulasta. Neulasta.
Yeah, I saw that in one of the articles I read, to take it for 5 days after the chemo, and they also said to add Claritin to it.
Yeah. So let's just take one at a time. The Neulasta, and there are alternatives to Neulasta because some systems don't cover the Neulasta and they give you a substitute that does the same thing. So Neulasta, you should definitely talk to your doc about whether he plans, and I would, if it were me, I'd be asking for it, to be honest. You want something to cover your white blood cells. If your red blood cells crash, there's something else, but we'll talk to you about it then. The Claritin is a very good, it's a very simple and a very easy way to combat several side effects. I'm not sure which, but I do know that Claritin is often prescribed. Anybody know how the Claritin helps? Herb, do you know?
It's an antihistamine.
Yeah.
And so it's going to prevent a lot of allergic reactions.
Right. Thank you. Yeah, that's allergic reactions and possibly some swelling. But the Claritin you can get over the counter, and it's really good to have.
Well, usually during your chemo itself, they give you a cocktail. They'll give you an antihistamine, they'll give you an anti-nausea, and they'll also give you a steroid.
Right.
All at the same time as part of the infusion.
Right.
So you may not need the Claritin afterwards. Just a word of advice from Ken Anderson. If you like to exercise and get sweaty and you have the Neulasta patch on, be careful because it can fall off and then it will not go off. It will not work.
Yeah.
And found that out.
Yeah, and yeah, all of the above, and also be aware of the dexamethasone high, Frank. Jake, would you like to just explain what we're talking about?
Well, everybody that talks to me after I've had my chemo day, everybody says, "Man, you sound good. You're talking like a mile a minute," and it's because the dexamethasone kind of gives you a little bit of a buzz. I don't notice it myself, but apparently it is very, very noticeable to other people.
I couldn't stop cleaning the house when I was in dexamethasone. My wife wanted to get me a prescription of it just because I was doing that so much.
The only thing I have to be careful about is I have diabetes type 2, and I'm talking with my diabetes pharmacist because of the dexamethasone, and make sure my Lantus will be able to take care of things during that while I'm taking the steroid.
You know, yes, very important, but your medical oncologist should take that into account, because you've got to remember he's also an internist, or she. I think it's a he in your case. So
yes.
if he knows, and the question you ask him again, this is a good question in writing, Doc, have you taken my diabetes into account? And ask him specifically, because you know that's why we feel so strongly about having a medical oncologist involved, because they're supposed to understand the side effects. And if they don't, then they'll call in. You shouldn't have to be talking to your pharmacist about it.
Got it.
Okay. Well, I think we've covered everybody. We still managed to retain 24 people at the end of the call. And I will be in Peter's or Len's or Herb's seat for the next 3 weeks, and I will enjoy that, because I haven't been in that position for a very long time. And so next week it will be Peter who's in charge and calling upon us as we have called upon him today. And if any of you have feedback on the new method, we had 33 guys on at peak and we're 15 minutes over. So we're getting there. We're getting there.
We'll give you 30 seconds if you need it, Rick.
Thank you very much.
Rick, when Dr. Ann Katz talks on Wednesday, do you get into that the same way as you do to these meetings?
Yes,
for presentation?
thank you so much, Robert, for reminding us. And I have a quick question for you, Robert, as well.
Okay.
But yes, Dr. Katz will be on this channel in this virtual room. And for those of you who don't know her, she's Canadian, John McPhee. She is very well respected in terms of counseling regarding intimacy issues, and she has agreed to speak to our active surveillance guys, but has agreed to take questions from everybody. So I think it'll be a really, really good session. Two very quick things. One is, Peter, your sound is not good. Again, sorry to tell you, I've got some comments just to me, but we got to get you fixed there, man. Either a new computer, a new sound card, something. You just got to put your foot down with those guys that you bought the contract with. It ain't good.
Right, can I say something about that?
Yes.
Real quick, Peter. It just that your mic seems to be hot, as they say. It's just too hot, and so it's distorting when you talk into it. If the signal is too strong. If there's a way that you could lower your microphone level, that may solve the problem all by itself. I'm not saying it will, but it might.
How does this sound? Does this sound any better?
Yeah, not really. Maybe it's just, yeah.
Okay.
It's messed
How
up.
come my buddies in India?
Okay. And
Peter, I'm willing to go one-on-one with you to debug it.
Peter, one quick comment. I heard you on a webinar about 3-4 weeks ago, and you were loud and clear like a bell. It's only on this site that you're not clear.
Well, it's more than this, but I will check on it again.
But Peter, as a backup, you can always dial in, and they hear you real well on a dial-in on the phone. You can do both. I do both.
I've been there, but I have a contract. I've run the phone with India about 2 or 3 times a week. They were supposed to call me today, and they didn't.
Okay. Do they, Peter? Do they? Will they deliver in curry as well?
Yeah. Yes.
Okay.
Very in a hurry.
Curry in a hurry. Mr. McAleese, the question I have for you is, how did you get the dream team at UCSF? Unbelievable. You must know some people. To get Feng, Larry Fong, I think you told us, and Peter Carroll. How did you do that?
Well, I started at UC Davis, and then I got some advice to switch down to UCSF.
Yeah.
And so I just called in. I think I just got lucky. I mean, I got really great people.
Unbelievable. I mean, that is, I don't even know. And especially Larry hasn't taken new patients in. We're sending, next time we need to get people at UCSF, we're going to send them to you first, right, Peter? Unbelievable. I figured maybe you had some in with Peter Carroll or something like that. You had some connection. Unbelievable.
No connection.
Okay.
Just blessed.
Okay.
I think God helped.
I think he did. I think the Almighty definitely had a hand in that. All right, guys. Listen. Happy New Year, everybody. May it be safe and healthy for all of you. And we'll see you next week. Goodbye.
Bye, Rick.
Good night, all.
Good night. Good luck, Frank. Good luck, Frank. Good luck, Frank.
Yeah, good luck, Frank.
Thank you very much. Thank you.